Hey everyone, we're going to get started in just a minute, just getting everybody in here. Excellent. We can get started. Thanks everyone for joining. Welcome to Avoiding Medicare Mistakes in Retirement. I'm Kim Basenbach, Director of Financial Planning at FSA Wealth Partners, and I'm really glad you guys could join us today. As many of you guys know, Medicare can be incredibly complex, full of rules, timelines, options that can be really overwhelming to navigate, which is why we believe in partnering with trusted Medicare experts who can guide our clients with clarity and confidence. We have the privilege of working with today's speaker, Margo Steinlage, for the past 4 years. Even one of our own team members have used her services. And Margo is co-owner of Steinlage Insurance and brings over 15 years of health insurance industry experience, along with a law degree, to her work. She's nationally recognized as a Medicare expert whose team serves thousands of clients nationwide to make Medicare planning a seamless part of retirement discussions. I really love her mission, which is simple but powerful, to maximize the Medicare experience and minimize the complexity, if that's possible. So a couple housekeeping items before we bring her in. First of all, there's a Q&A at the bottom of your screen. Please put any questions in there. We've done this with Margo before. She's great about incorporating people's questions into either the content or make sure she hits it at the end. And then at the end of the webinar, we should have a survey that pops up. Please give us any feedback on what you thought of today's webinar. So without further ado, Margo, I'll hand it over.
Awesome. Thank you so much, Kim, and the whole crew over at FSA for letting me jump on my soapbox for the next hour. And thank you guys for attending this Zoom session. A little bit about our services here at Steinlage. I won't go into them in too much detail, but everything we do is free. We are an independent health insurance agency. I get my entire team certified and educated and trained with all of the national insurance carriers and regional insurance carriers that are out there on the ACA under 65 product, in addition to the Medicare product. So when you work with myself and my team, you are getting a unbiased, just neutral assessment of what's available out there at no charge to you. So whether you plan to move Medicare at 65 because it's required, or maybe you're juggling COBRA versus an ACA analysis, or Medicare versus staying on the large group plan scenario, our team is giving you just kind of a high level advice and strategy session. And then when you are ready to move to Medicare, we are paid by the insurance carriers that are heavily regulated by Medicare. So whenever you do move into Medicare, we could care less which product you choose. Again, our goal is for you to be educated and informed of all of the pros and cons to your decision as you make this transition into either ACA or Medicare at 65, and then provide support throughout the year, and then also follow-up support when we approach that Medicare open enrollment period in the fall, or the ACA enrollment period in the fall. So it's never a like set it and forget it relationship with myself and my team. We are there for pre-enrollment strategy support, enrollment support, and then also post-enrollment follow-up and review support. We are in all 50 states, so once you work with our team, our services follow you, and we help you navigate health insurance regardless of where you retire or move after retirement. So if you're in Maryland or Virginia and then you transplant over to Florida, we're here to support you in that transition and process. Today, we're going to cover a lot of information, and if you've joined or attended one of these events in the past, awesome, great to see you again. But if you've been here before, I go into great detail with regards to Medicare and rules and regulations. So if you have a notepad and a pen, grab it because you may want to take notes. But I know this event is recorded, and Kim will share this after the fact. And then I can also make my slides available. Kim, I'll share those with you after the fact so you can distribute those as well. But today, for the next 40 minutes, 45 minutes, I will cover kind of three main parts of Medicare. We're going to define like what's required at age 65, who is eligible for Medicare, what needs to happen at age 65 so that you can avoid lifelong penalties or gaps in insurance. And then who can avoid Medicare at 65. So we're going to define those rules. And then next, we're going to look at the moving parts of Medicare, Medicare Advantage, Medicare Supplement, also known as Medigap. How does Part D prescription drug coverage fit in, along with dental and vision? What's Part A? What's Part B? There's a lot of terms that get thrown out there, a lot of moving parts of Medicare. We're going to look at it at a high level and then dissect that and go into kind of plan-specific strategy. And then lastly, we're going to look at IRMAA for my high earner clients, and then also how this big, beautiful bill and the Inflation Reduction Act from back in 2022 are changing your exposure once you do move into Medicare. So let's jump in with kind of the general rule around turning 65. So who has to sign up for Medicare? So when you turn or approach your 65th birthday, the general rule that I like to tell clients is that you must sign up for Medicare upon turning 65. You have this beautiful 7-month window, 3 months before your 65th birth month, your birth month, and 3 months following your birth month, your 65th birth month, where you can sign up for Medicare. You can opt into Medicare if you're not collecting Social Security, or if you're collecting Social Security, you're automatically enrolled in Medicare. But during that 7-month window, as you turn 65, you need to sign up for Medicare Part A and Part B to avoid lifelong penalties or gaps in your health insurance. The exception to this rule that you have to make a decision and have to move into Medicare, whether it's proactively or automatically because you're collecting Social Security, the exception to that general rule is if you or your spouse are actively working with a large employer, then Medicare enrollment becomes optional. So long as you or your spouse through active employment, you can't be retired, so long as you and your spouse through one of your active employers' employment has access to large employer group health benefits and you are enrolled in that group health plan, then Medicare is optional. So we can decide, does it make sense to continue working and staying enrolled in that group health benefit? Or does it make sense to carve off and move into Medicare? All right, so Medicare is not required, and the size of the employer is the determining factor on whether Medicare is required or not. So if you're working with a large employer, 20 or more employees, it doesn't matter if those employees are full-time or part-time, then Medicare is optional. If there's fewer than 20 employees, then Medicare A and B is generally required. You need to sign up for Medicare to avoid penalties and gaps in your insurance. So a few red flags to kind of dance around and watch out for as you're making these decisions. If you or your spouse are working with that large employer, 20 or more employees, and you love your health insurance, you have great coverage, your employer is subsidizing the cost quite a bit, and it's very affordable and attractive. If you have an HSA component that you're contributing into, it's an HSA-Qualified group health plan, you can't enroll in any part of Medicare and still contribute into that HSA. IRS does not allow you to enroll in that free Part A hospital benefit of Medicare and take advantage of the HSA contributions and tax benefits there. So again, if you're working with the large employer and you're maxing out your employer's HSA, the HSA benefit, you need to opt out of both Part A and Part B. All right. And now later, when you're ready to retire and come off that large group plan, regardless if it's an HSA qualified plan, you'll create this special enrollment period that will allow you to select or enroll in Medicare Part A and Part B at a later date without any gaps or penalties. All right, so if you're on that large group health plan and you're maxing out the HSA, and now you say, hey, Margo, I'm ready to retire January 1st of the given year, we need to watch out for that HSA contribution the year you're planning to retire with that Medicare enrollment kind of timeline. Because here's why. When we submit your Medicare special enrollment paperwork to elect Medicare for the future date, your Part A hospital benefit will have a 6-month retroactive look back from the month prior to paperwork submission. So here's an example. You want to retire January 1, you want to move fully off your group health plan into Medicare January 1. You contact us, we're going to start that paperwork Medicare submission in October for the January 1 transition. Medicare Part B will take effect January 1, which is what we want, but the Part A benefit will go retroactive 6 months prior to the month we submit, which would be October 1. In this example, you'll see an April 1st Part A hospital benefit effective date, and we need to time your HSA contributions to take that Part A retroactive effective date into consideration. In this example, you can contribute 3 months into your HSA for 2025 based on this timeline. January, February, March, you can contribute 1/4 of the allowed amount for 2025 because Part A is going retro to April 1st of 2025. Your transition to Medicare happens January 1st of 2026. All right, so that HSA contribution and math equation needs to be on your radar because of this 6-month look back. If you are approaching 65 this year or next year and you know you want to continue contributing into your HSA, then you need to be conscious that, hey, I can't collect Social Security because it triggers the Part A benefit, nor do I want to sign up for the free Part A because I want to continue contributing into my HSA because you're turning 65. So if you have questions on that, I put my information in this chat. Feel free to shoot me a personal email after this event, and I'll be happy to make sure you're making the right decision and kind of timing your HSA if this is specific to you. Again, if there's fewer than 20 employees, then you need to consider moving into Medicare because Medicare secondary payer rules require Medicare to be the primary payer. And the small group, 20 or fewer employees, the small group plan is now secondary. And now we're strategizing, does it make sense to keep that small group benefit as a secondary payer to your primary Medicare? Or does it make sense to fully move into Medicare with a supplement, a drug plan, or an advantage plan? Maybe you have a spouse or children that are impacted by your move into Medicare. If we need to consider their options, we can look at ACA or COBRA, or maybe keeping the small group plan instead of moving fully into Medicare. All right. Also, once you are on Medicare and you're using those HSA plans, or funds, excuse me, we can use those HSA funds for many reasons. The only thing you can't request a reimbursement for is your Medicare supplement, also known as Medigap premium. So you can use your HSA funds for reimbursing your IRMAA, your Part B premium, your drug deductibles, any co-pays on medical, dental, vision. You just can't use it on the supplement or Medigap premiums. All right, I know I'm throwing out a lot of terms, and if this is your first time watching a Medicare kind of 101 presentation, let me give you just some terminology and define the language here. because Medicare is a foreign language, especially if this is the first time you've heard some of these terms. So Medicare, your red, white, and blue card that you get when you fully enroll in the system, consists of two moving parts. You have the Part A hospital benefit of Medicare and your Part B medical benefit. These two moving parts make up original or traditional Medicare, and that is your red, white, and blue card. So when you enroll, you have to opt in or enroll in Part A and Part B, medical and hospital. For most of us, we pay no extra premium for our Part A hospital benefit because you or your spouse or ex-spouse have a combined work history of 40 quarters, which equates to about 10 years worth of work history. You paid into the system, now you reap that Part A hospital benefit at no premium. Many of us will pay the standard Part B premium, which for this year, 2025, is $185 per month per person. This standard Part B premium is adjusted based on your income. So if you or a family member are qualifying for the state Medicaid program, then Medicaid will come in and offset or cover your Part B premium on your behalf. If you are a high earning individual with a modified AGI above 106,000 is a single tax filer, or 212,000 is a joint filing couple, then Medicare Part B premium, the standard premium, is much higher. You'll see a income-related monthly adjusted surcharge placed on that Part B premium, and that income surcharge is called IRMAA. I will cover IRMAA and define IRMAA towards the end of the presentation, but I just want to sprinkle that in there now because IRMAA comes into play and will increase your exposure on Part B premiums in addition to any drug benefit that you select, Part D. Okay, so moving into Medicare is not free. Medicare does cost most of us at least that Part B premium plus any IRMAA income surcharge if you are a high earning individual into retirement. So this is your red, white, and blue card. If you walk in the hospital, you have a horrendous medical year, you walk in the hospital 3 or 4 times for a few weeks, you get outpatient surgery, you get, 3 to 6 follow-up treatments, you have 6 months of PT. All of those claims are being picked up by Medicare, but there's gaps in Medicare. Medicare doesn't cover everything. So if you walk in the hospital, Medicare has a $1,600 deductible, roughly $1,600. And that's per 60-day occurrence. So if you go in January and then you go in again in June, essentially you're meeting 2 different Part A deductibles because of that reset. If you walk into the medical, if you see a cardiologist, you have your colonoscopy, or you're having an outpatient surgery, you're required to pay the Part B small medical deductible for the year, which is $257, and then Medicare covers 80% of the claims. Your 20% risk is a large gap in the Medicare coverage that Medicare won't touch. You're responsible for the 20% remaining with no cap or ceiling on your out-of-pocket exposure there. Also, Medicare Part D, the prescription benefit, is not part of this standard red, white, and blue card. There's no drug coverage built into this red, white, and blue card. There's no dental built in. There's no hearing built in. There's no long-term care built in. These are all ancillary benefits that you need to pick up or insure to fill the gaps of original or traditional Medicare, that red, white, and blue card. So how do we fill the gaps of original Medicare? Really, there's 2 pathways that you can opt from. And maybe you are lucky and you have a really awesome retirement package from your employer. We can also compare that to these alternative pathways. I will put this out there. If you are a federal retiree or you have TRICARE, we do not coordinate and work with federal retirees or military because those are totally opposite from this setup here. Okay, if you are a federal retiree or have TRICARE, please reach out to me. I'm happy to give you a contact of mine that handles the federal retiree and Medicare conversation. Unlike us, we're free. She does charge a fee for service for those federal retiree consultations. For the rest of you, I can work with. I can help you navigate, these options and ancillary benefits, and to see which option is going to be best based on your needs, your prescriptions, your doctors, your goals. So here, again, we have a decision to make. Do you want to move into Medicare? Is it optional because you have access to large group? Or is it required because you don't have large group, or you're retired, or you're on ACA, you're on COBRA, and you're turning 65? You have to move into Medicare. What does that look like? How do we sign up for Medicare? And now, once we're in Medicare, what option? How do we fill the gaps of original Medicare? Here, most of my clients, because I get a lot of advisor referrals coming from wealth managers, CPAs, estate planners, most of my clients tend to go this supplemental option 1, Medigap, supplemental and standalone drug plan pathway. Some of you may opt for a Medicare Advantage plan, and that's perfectly fine. About 55% of the population will go Medicare Advantage. 45% of you, on average nationally, will go supplemental. So my goal today is to kind of give you the pros and cons of each of these pathways so that as you approach your Medicare eligibility, you already are armed with like a really good foundation of which pathway you want to take. And now you can kind of move through all the noise and opt for the right coverage based on what you know. You're not getting sold a policy that in 2 years you're going to regret purchasing. So I will say, before I jump into kind of the pros and cons of these pathways, no matter which route you ultimately end on, this Part B standard premium, the $185 per month plus IRMAA, the income surcharge, if we can't appeal it and reduce it, those are standard cost and will hang out in the background regardless of your pathway decision. If you choose supplement versus advantage, you are responsible for that Part B premium and any IRMAA. Okay, so keep that in mind. That's going to be a fixed cost regardless of your plan design. Now, if you are a client who says, hey, Margo, hey, Team Steinlage, I really want awesome coverage. I travel a lot. I had a poor experience with a network plan in the past. Most of my doctors are only taking Medicare. They're not playing the game with these insurance carriers. Whatever your reason, this Medicare with a supplement in the drug plan is kind of the Cadillac pathway that you can opt for when you're looking at Medicare coverage. Here you have original Medicare as your primary payer, which means you can go to any doctor nationwide that takes Medicare. You show your Medicare card to the provider. The provider bills the Medicare. Medicare pays its 80% and submits the residual exposure over to your supplement carrier or your Medigap carrier automatically. That happens automatically. And now your supplement plan will pick up the residual cost after Medicare pays. So here, the best level of coverage that you can get under this Medicare with a supplement combination is called a Supplement Plan G, as in girl. When you have a horrendous medical year and you have this level of coverage, Medicare is your primary and your Supplement G as your secondary, you can go to any provider nationwide that takes Medicare. You will never ask the provider, do you take my Care First supplement or my Aetna supplement or my AARP supplement? The question you will always ask is, do you take Medicare? Are you a Medicare provider? And about 97% of providers take Medicare on a national level. So here, if you have Medicare with a supplement G, your only exposure for that horrendous medical year with regards to medical and hospital claims is that Part B medical deductible of $257 per year. After you meet that, Medicare and Supplement G are paying 100% for the hospital and medical claims. In addition to this Medicare and Supplement package, you would also add a standalone drug plan. These plans range anywhere from $0 to about $150 per month, and they will cover your prescriptions, and we modify that drug coverage each year based on your up-to-date drug list. So it's never a set it and forget it in the supplement and drug plan market. We are always looking at optimal coverage, whether it's premiums being paid or prescriptions and formularies. Okay. So we reach out every year so that we can obtain up-to-date information, and we go to work on our end and make plan recommendations each and every year, which is a very unique service. I wish my PNC and my car insurance broker would do this for me. I have to get squeaky each year and say, why did I go up $600? Can you shop it? It's not proactively being done. So here, once you become a client of ours, then we are sending you our intake form. And if you're on here and you're already a client, and maybe you're watching for a spouse who's approaching Medicare age, you actually will be receiving our intake form by end of next week, if not earlier. So be on the lookout for that. So the negative to this level of coverage is that it can get expensive. You're paying Medicare, IRMAA, supplement premiums, drug plan premiums, a dental and a vision package if you wanted to add that. And these premiums are increasing each year based on, inflation and market adjustments. You're not guaranteed to pay this premium that you are paying the month you get in. You're not guaranteed to pay that for the next 20 years. So these premiums are getting more and more expensive each year. But on the flip side, the positive is you have rockstar coverage. There's no network, very limited pre-authorization involved in the Medicare market. I can't say it's non-existent anymore because of new rules, but very little just dictatorship from Medicare. The negative, it's expensive. On the flip side, the more economical pathway for some of you may be this Medicare Advantage pathway, also known as Part C. And here, you have to have Medicare Part A and B. That red, white, and blue card is required in order to enroll in one of these zero premium Medicare Advantage packages. So think of Medicare Advantage Part C as combining your Medicare Part A, your Medicare Part B, your prescription drug, your dental, your vision. It combines all of the hospital, medical, drug, dental, vision, hearing into one bundled package called Medicare Advantage. And typically these are zero premium, which makes them very attractive to somebody who is healthy. All right, you pay nothing to hold your coverage. Some of these Advantage plans even offer a Part B reimbursement. They'll cover some, if not all of this Part B premium. Okay, so these Advantage plans, UHC, Humana, Aetna, Care First, Johns Hopkins, they are all very attractive. However, the negative is that if and when you get sick, you are in a network of doctors that you are required to stay in network with. If you have a PPO, which allows you to go in and out of network, you have to make sure and verify that your out-of-network provider will agree to the terms of the PPO plan prior to seeking care. Also, the PPO plans have pretty outrageous exposure on the out-of-network charges. Typically, your max out-of-pocket in the DMV on HMOs and PPOs currently are anywhere from about $4,000 to $10,000 a year in out-of-pocket exposure. Some are even 11 or 12. So this can be a very attractive pathway if you're healthy, you're okay with the network restrictions, you're okay with the pre-authorizations that can come into play. Just be aware that there can be some headaches and hurdles down the road when you're seeking care, but it can be very affordable. You're cutting out the drug costs, the drug premiums, you're cutting out the supplement premiums, you're even cutting out the dental and vision premiums, and maybe even some of your Part B premium. The negative, though, the biggest negative is once you choose this Medicare Advantage pathway, if you ever, year 3, year 5, year 10, year 15, you're super sick, you're hitting and you're getting sick of these network restrictions, you don't like your plan design each year, these plans are continually squeezing the networks, they're throwing on more restrictions like pre-authorizations before they'll cover care. At any point, if you say, Margo, this is the pits, I need comprehensive full access to nationwide coverage or no networks, I want to go back to that Medicare supplement pathway and drug plan pathway so that I can seek care from any Medicare provider, not just my Advantage Plans network doctors. Now you're outside of this new to Medicare window where you can get a supplement with no underwriting, no health questions. So as soon as you opt for this Medicare Advantage plan pathway, when you turn 65 or you're coming off that large group plan at age 70 and you're picking up Medicare for the first time, you're moving into the system for the first time, you have this 1 year or 6-month trial period to get into your supplement with no underwriting. But outside of that 6-month window, now when you want to drop your Advantage plan and go over to the supplement pathway for comprehensive care, limited network, now you're kind of locked out because of your health risk. And really the only reason many of you will ever drop this zero premium plan is if you're experiencing a frustrating, care or frustrating service from the Advantage plan, that's when you want to drop it. And at that point, these supplement plans are going to say, we're denying you access because of your high health risk. We can now require medical underwriting because you're outside of this new to Medicare window. Okay, so long story short here is you can get stuck if you become a high health risk, you have a chronic care need, you're on tramadol, you have physical therapy, you can become a high health risk in the eyes of these supplemental carriers and denied access to the supplemental carrier at a later date if you don't initially opt for this supplemental plan when you're moving into Medicare for the first time. So I say this because buyer beware. These supplements are very attractive, but be aware that the premiums increase. These Advantage plans are very attractive because there's zero premium, but be aware you can get stuck in that Advantage plan product, even though you can go carrier to carrier, HMO to PPO, Aetna Advantage to Humana Advantage to Care First Advantage. You can bounce around, but you can't move over to that supplemental package unless you have a clean bill of health. You're a low health risk. Okay, so your initial decision here has long-term consequences. Buyer beware, do your due diligence, make sure you're getting the right pathway day one. Don't try to game the system because you might get funneled into a product you may not want when you're 80. Okay, so my goal, I do these education events every year for our current clients just so they know, my premiums went up again 20% or 15% or 10%. 10% is the national average right now. They know each fall when they're getting bombarded with solicitations and phone calls asking them to move to the Advantage product, they know oops, if I do go Medicare Advantage, what's the consequence? What's the oopsie? How do I fix that if I want to move to the supplement at a later date? Might be hard if you're a high health risk. Okay. So again, education is key here so that you're making the most well-informed decision based on your financial goals, financial needs, your health risk, your health needs, and your ever-changing prescription drug list. If you have any questions on this kind of tit for tat coverage, which route is best for you, again, shoot me a email, or you can pose a question in the chat. I'm happy to look at those, but I'll continue on. Okay, so this Inflation Reduction Act that was passed in 2022 has radically changed the Medicare drug market for most of us. So in the past, there was this opaque manufacturer's just donut hole exposure where you never had a full cap on your out-of-pocket exposure on drugs once you moved into Medicare. Well, now this year in 2025, the most somebody will pay on covered medications under any of these Advantage plans or drug plans, standalone Part D drug plans, the most you will pay for covered medicines is $2,000. So this drug cap is huge. It's amazing regulation because many clients were on crazy expensive medicines and there was no cap on their out-of-pocket exposure. Now, if you're on, expensive medicines, $2,000 is the most you'll pay. The negative to this regulation is that these drug plans, whether it's an Advantage plan or a standalone drug plan, Part D, these drug plans are now responsible for any cost on your medications after you meet that $2,000 out of pocket. That's a huge risk and a huge liability for these drug plans. My dad, he'd hate me for saying this, but he's on a very expensive migraine medication. He had vertigo, and he's on Nurtec, and it's like $1,600 for 16 pills. His drug plan is paying almost all of the cost of that exposure because my dad hit the $2,000 cap, a month and a half into holding his drug plan. So the negative to this regulation is that next year we anticipate higher than normal rate increases because of this new exposure these insurance carriers have under the Part D benefit design. So if you're already on Medicare and you're watching this, or you're moving to Medicare at the end of this year or into 2026, this is definitely something that's going to come up. And we will want to make sure we're watching the pricing on these drug plan premiums, not only this upcoming year, but each year thereafter. Again, I highlight the statement, this is not a set it and forget it relationship with us and our team. We need, because of this volatility, we need to review coverage each and every year. Okay. Also, if you are planning to stay on your large employer group health plan, maybe you have that HSA component that you want to max out, this upcoming year, there will be changes to how these group plans calculate their drug benefit under the group plan. And if they do not meet new requirements as of January 1, the drug benefit design under your large employer plan may become non-creditable coverage, meaning it doesn't meet what Medicare requires. And if your drug plan under your large employer group health benefit, if the drug design doesn't meet that new requirement, then you have to move to Medicare. You can't stay on that large group medical benefit because of the drug design. So this is brand new. We are closely watching how this unfolds. I work with a lot of the group brokerages around the DMV. But this is definitely going to impact decision making. For those of you who are working with large employer plans, we have to make sure that your plan, if you're going to stay on it for next year or even throughout this year, we have to make sure that your coverage is creditable, it meets those Part D drug design benefits. If it doesn't, then you can't delay Medicare Part D. You have to move into Medicare Part D, which impacts your ability to stay on that group health plan for the foreseeable future. Okay, I don't want to go too far into detail here because many of you, it won't impact your decision making. But if you get a letter or you're working with us and we are looking at your high deductible group health plan, this will and may impact your decision. All right, we have a question on that one. Oh, that's just Mike. Okay. All right. I'm going to continue moving along, and Mike, if Sue asked the question, amazing. Okay, IRMAA. So I mentioned IRMAA at the beginning of the presentation. This is going to come into the equation if you are a high-earning individual. So if you moved into Medicare in 2025, Medicare looked at your filing, your tax filing status, and your modified AGI from year 2023 to set your 2025 Medicare premiums. Automatically, each year in December, Medicare and IRS communicate and will automatically update your IRMAA owed based on your prior 2-year tax return. So in December of this year, Medicare is going to send you all a notice if you're on Medicare that says, hey, for 2026, we're setting your Medicare and IRMAA premium at X because we see your 2-year look back 2024 modified AGI was Y. Okay, so that happens automatically. In 2026, Medicare will be looking at your 2024, 2027 automatically updates based on 2025's tax return. What Medicare doesn't realize is if you've had a life event, you stopped working this year, you retired, you reduced your work hours, you had a death of a high-earning spouse, you divorced your high-earning spouse. If you've had a life event, then we can tell Medicare, don't use that stale 2-year tax return. I've had a life event. Here's proof of my life event. Here's my divorce decree or retirement letter from my employer. Use my anticipated modified AGI for this year or next year to set my premiums. All right, so we can appeal and reduce or request a full removal of any IRMAA owed based on this life event and your projected or your anticipated modified AGI. And that's where I like to bring in your advisor. FSA can help us anticipate and draft or designate a modified AGI, an anticipated figure based on what you're doing with your investments and kind of your whole picture. I don't have access to that. Your advisor does, and I like to bring in advisors, CPAs, kind of the whole squad to get a good assessment of your modified AGI for retirement years. Because you can see here, you and your neighbor can have radically different Medicare experiences. And I'll give you an example. My neighbor is on Medicaid, paying next to nothing for her Medicare premium because it's all offset by Medicaid. And maybe she's on a dual Medicare Medicaid Advantage plan, 0 premium. So she's paying next to nothing for all of her medicines. All of her copays are comped and covered by Medicare and Medicaid. Okay, so she's paying nothing. Medicare looks amazing for her because it's cheap and it's covered by Medicaid, her state program. I, on the other hand, have a high earner in my family. And I am paying the highest IRMAA. I'm paying $700 a month just to hold my Medicare. And then I want the Mac Daddy Supplement G because I travel and I don't want any dictator managing my care or authorizing care or restricting my care. So I pay up for the Supplement G. I'm on expensive medicine, so I'm on an $80 Part D drug plan. And I want dental and vision because I go 2 times a year and I have family history of dental care needs. True story. My husband and I joke that we have a Mercedes-Benz in our mouth. So I want good coverage and I'm going to pay for good coverage in addition to that IRMAA being attached to my Part B and Part D premium. So to get in the door with Medicare with my Supplement G, my nice drug plan, and my nice dental and vision package, I'm running at $900 to $1,000 a month for my package when my neighbor pays nothing. Okay, so I say this because I can't tell you how many times clients come to me and say, my neighbor pays nothing. Why am I paying something? And I have to explain every person's experience in Medicare is radically different. Even a husband and wife or partners may have radically different experiences depending on their appetite for risk. Some husbands or wives will go, or spouses will go Medicare Advantage, and the other partner will go supplement or flip-flop. Some are on expensive meds and need the more expensive drug coverage. Doctors are different. So everybody has a unique experience under Medicare. There is no one-size-fits-all approach. There's no family package. This is all individualized based on your unique circumstance and health needs. Okay? This is something, this IRMAA appeal is something we help you walk through. We put it on your radar each year based on our Zoom event. We bring back the IRMAA into the equation. If you are having a one-off spike, maybe you sell a home, you sell a business, can we appeal that IRMAA? Do we need to ride out IRMAA for the year until it drops back down based on that 2-year look back? Now, once you're on Medicare, when can we review coverage? So this October 15th through December 1st timeline is when somebody who is already on Medicare can shop their coverage. It's a time to shop your drug benefit or your Advantage plan. The supplements can be shopped anytime throughout the year based on your birthday. So Maryland, Virginia all have unique birthday rules that allow you to shop plan to supplement on your birthday. All right. Many states are picking up these birthday rules. Not all states. DC doesn't have it yet. But I would say close to half of the states currently have a birthday rule that allow you to shop your supplement. All right. So these enrollment periods are important if you're already on Medicare. If you're not on Medicare, then your 65th birthday is kind of what's the initial deciding factor on whether you have to move Medicare or can you delay Medicare if you're on that large group benefit through your employer, your active employer. COBRA is not active employment, or your spouse's active employment. All of these premiums I'm stating are per person. IRMAA will affect both individuals in the family if you're filing jointly. There's a different IRMAA bracket if you are filing separate but married. Okay, and you can see here this third column. It's hard to cheat the system. If you are making anywhere above 106,000, you're right up to one of the highest IRMAA brackets is a married but filing separate. So if you're going to ask me, Margo, should I file separately? I'm going to bring in your CPA, but I want you to be aware that the IRMAA brackets are different for that scenario. Okay, also for anybody who may have a younger spouse who's impacted, or maybe kids who are on your group plan and are turning 26, and maybe you're getting kicked off that group plan at age 26. The ACA under 65 market, also called the Maryland Exchange or the Virginia Exchange or the DC Health Link, these under 65 markets are being impacted by this big, beautiful bill and just regulations that are expiring by the end of the year. So under Biden, we had this enhanced tax credit access that many of us were able to tap and get really affordable ACA, Obamacare, Trump care, individual coverage that was heavily subsidized. that subsidy extension is being expired but at the end of the year. It's terminating. There's no regulation right now or bill that is approved to extend those subsidies, the extension, into 2026. So I say this because most ACA plans, under 65 individual plans, are hedging their risk here. And we are hearing that the average increase to these ACA plans is projected to be about 16% for next year on their premium. Plus, many individuals losing access to either Medicaid or that enhanced subsidy credit access that many of you received in the last 4 years. You won't be able to tap that or receive it in 2026. So I'm just planning this early that, hey, you may see really expensive ACA sub premiums next year. Further, there's total plan exits happening. Aetna announced that it is removing its ACA product from all states that it's in currently. So if you're in Inova and you have Aetna Inova on ACA in Virginia, if you're in Maryland and you have Aetna on your ACA plan, you have to make a change for next year because you won't have access to individual Aetna product next year. So it's a major disruption. Some markets, Aetna is the only carrier that covers kind of the higher, more expensive hospital systems. All right, I'm from Missouri. Aetna is the only one that covers the big hospital there. So we are like on pins and needles to see who picks up this coverage gap that is left in the wake of Aetna exiting. So again, I'm just helping you forecast. Also, if you are moving to Medicare and you have a younger spouse that's being impacted, any ACA bronze plan next year will be HSA qualified plan. So right now, and in years past, you had to actively enroll in an ACA marketplace qualified HSA plan. Next year, all bronze plans become HSA qualified, which may help you keep your modified AGI low, tapping into the normal subsidies, not the expiring extended subsidies. Further, you can get the tax benefit of having the HSA maxed each year. So that's a positive, but there are some negatives coming down the pipeline for ACA because of these regulations and expiring subsidies. Okay, I know I talked about a lot. But if you guys have any questions, again, we are a free resource to you. FSA and my team have a fantastic relationship. We worked with many of the advisors at FSA, and they've worked with us for many years. So feel free to shoot Kim an email or Mike an email or myself an email. We are all here to support you as you make these transitions, whether it's into Medicare or early retirement, and you just need to juggle the COBRA and ACA conversation. Just reach out to us, okay? I'm going to put my information here, and I'll leave this up, Kim, and I'll let Kim hop on here and say goodbye, but I am available for the next few minutes, so feel free to shoot any questions in the chat.
Thank you, Margo. This was wonderful. And yeah, just to reiterate, her information's here. You all most likely have me or Mike's contact information. Let us know if you have questions. Happy to get you either connected with Margo, or as she mentioned, if you're on the federal side or military side, we can get you connected to someone over there as well. Thanks, everybody.